to another compelling episode of MedSynapse podcast series. I'm your host, Tetvi Shah, and today we are diving into a topic that often flies under the radar: how skin health plays a pivotal role in preventing pediatric infectious diseases. From common bacterial infections to serious complications like sepsis and rheumatic fever. The skin is not just a barrier, it's a frontline defense. And to help us unpack this vital topic, we're honored to welcome back one of the world's foremost leaders in pediatric infectious diseases, Professor Asha Bowen. Professor Bowen is a pediatric infectious diseases specialist at Perth Children's Hospital and the head of Healthy Skin and ARS Prevention team at the Kids Research Institute in Australia. She is also the president of the World Society of Pediatric Infectious Diseases. She has over 15 years of experience leading clinical trials and community-based interventions, including the landmark STOP trial. Her work has not only shaped National Skin Infections Guideline Australia, but is transforming how we approach child health globally. So, Professor Bowen, welcome back to MedSynapse, and it is such a pleasure to have you with us again.
Thanks for the invitation.
So, doctor, to begin with, Staph aureus and Group A Strep have long been at the forefront of pediatric skin infections. So, are we seeing any changes in the microbiology of these infections, and how should clinicians adapt their diagnostic and treatment strategies in this response?
It's such a good question because the microbiology guides antibiotic choices. And some of the history has been that impetigo, probably back in the 1950s and 1960s, was thought to be entirely Group A Streptococcus. And then probably in the 70s into the 90s, it was thought to be entirely Staph aureus. And so when I came to work on skin sores or impetigo in my PhD in the early 2000s, I was sort of expecting that perhaps it was a mostly staph disease. And so we were trialing in the skin sore trial, which predated the STOP trial. We were trialing to see whether oral cotrimoxazole would work just as well as an injection of benzathine penicillin G. What we found out was that oral cotrimoxazole was great. It treated both Group A strep, Staph aureus, but also methicillin-resistant Staph aureus, or MRSA. The key feature that I found during that PhD work was that actually the marker of infection resolution was actually getting rid of the Group A strep. So we found out through that process, probably some deductive reasoning, that Group A strep is the inciter of impetigo. It's the pathogen that's causing impetigo, and staph comes along for the ride. So it's not uncommon to find both bacteria there at the same time, but it's really the Group A strep that's causing the problem. And so that's led to a lot of reconsideration of our primary prevention activities for rheumatic fever, as well as thinking about the skin, as you described it, as a really important defense against sepsis for both Group A Streptococcus and Staph aureus.
Yeah, I think that's a critical update, I would say. And then distinguishing these is also very important and critical, I would say. Now, doctor, let's just touch upon the environmental impact also, rising global temperatures and shifting towards humidity levels are changing the infectious disease landscape. So, are you seeing an increase in certain pediatric skin infections, and are tropical or neglected infections like cutaneous leishmaniasis or atypical microbacterial infections becoming more widespread?
It's a great question. And I think that there are many factors at play when you consider the burden of skin infections. I think humidity and heat together, so the tropics have always been thought to be a great place for skin sores to progress. And that's probably because the bacteria survive better in that humid and warm environment, as well as people are exposed more to, say, mosquito bites or not having protective clothing on because they're so hot as well. So there are lots of ways in which the climate interacts, I think, with skin problems. It also, I think, predicts some tinea infections, and it's probably more so in the tropical areas. And I use the tropical areas as a bit of an example for the way in which climate change can then have an impact, where we see more of the sort of mycobacterial skin infections. It's probably twofold, also associated with lower socioeconomic status, so lower middle income country settings where we might see more leprosy, more skin and soft tissue infections, more scabies, those kind of things. But it's also where these countries are located from a climate perspective close to the equator, where we're seeing more of these things emerge. And I don't know that there are any good studies yet to describe how climate change is impacting on skin infections per se. But I suspect if we started to gather that data and look at the huge variety of different ways in which the skin can be infected, we would start to see some trends emerge. One thing that does come to mind when I think about this is our burns unit at our hospital often reports that staph infections and folliculitis in kids with burns are at a much higher rate in the summer period, where we have a temperate climate, than in the winter period. And so that's sort of like in southern Australia where we're seeing sort of those impacts. If we see more and more hot environments, we're probably going to see more skin infections as well. So another good reason to really address climate change as a collaborative effort.
Yes, I think there should be studies on environmental impact also on your skin, because that's, as you mentioned, is really important also these days. So now, Dr. Naina, we all know that basic hand hygiene is very essential, but often neglected. So beyond that, what skin hygiene practices should pediatricians and parents prioritize today to effectively prevent bacterial and fungal infections?
So hand washing itself is a really simple strategy and has been shown in clinical trials. Hand washing once a day reduces the rate of skin infections. And so these trials were done in lower middle income country settings. And so I think it's just once a day had this impact. So I think if we're regularly washing our hands with soap and water or using an alcohol gel, then we can expect reductions in that bacterial skin infection, so impetigo. That's because we use our hands for so many different things. We're often touching our face or scratching ourselves. For little kids, I think most parents will say, probably most pediatricians, they've often got their fingers in their nose and their mouth. So there's places where staph and strep like to live and can be then transported across the body. So hand washing, I think, is a really good practice for so many reasons, but it also helps to maintain good skin health. We also know that regular bathing is a good, standard to help maintain good skin health. And it's kind of a balance between access to water to bathe and then the dryness of the skin after bathing. So trying to get that right balance between what is accessible and then what can be done. But all of those activities do help reduce skin infections and are really good preventative strategies that parents can adopt.
Absolutely, yes. Yeah, I think those are really valuable protocols or I would say basic prevention measures that could be taken in each household. Now, doctor, given the growing concern around antimicrobial resistance, when is it appropriate to treat pediatric skin infections with antibiotic, and when is supportive care enough? And also, are there any promising non-antibiotic therapies on the horizon?
Yeah, it's a great question. And I think antimicrobial resistance worries all of us. And so it is prudent to use antibiotics wisely. So not treating infections that might get better on their own, but making sure those infections that could progress are offered antibiotics as well. So it is definitely a balance. What we've now written into guidelines is if a child has less than 2 skin sores, then they could be treated with topical therapies. So a topical antibiotic, in our country, muffurosin is the most common one, but in other countries there are fusidic acid and some other topical antibiotics get used. These are not non-antibiotic options, but I think a local topical cream is probably going to generate less resistance pressure than taking an oral antibiotic. But if there are more than 2 sores on a child, then we recommend oral antibiotics for that. And then really understanding what the local antibiogram is for resistance profiles, so you choose your antibiotic wisely. One thing I will say to everyone is you don't ever need 2 antibiotics to treat strep and staph at the same time. So oral cotrimoxazole or Bactrim is a great option to be able to cover both Group A strep and staph. But if you don't have much resistance in your area, you can also use cefalexin as an easy oral antibiotic that kids like to take that doesn't require giving an extra one. Quite often I chat to colleagues around the world and they're often trying to use 2 antibiotics to treat the 2 bacteria at the same time. My approach as a pediatric infectious disease specialist is always to try and come up with the easiest solution for children and families. So making sure it's the fewest number of doses per day, making sure that it tastes pretty good, making sure that it's easy for them to swallow, and the shortest possible course. So really thinking about all of those strategies when you're providing a prescription for antibiotics that are really child-friendly and focused on their needs and their ability to use the antibiotic wisely as well.
Yes, I think that's a much needed perspective for the pediatricians and general practitioners as well, doctors.
Yeah, I would add as a pediatrician that I've always tasted the antibiotics myself just to find out and some of them are really bitter and some of them are really sweet. Some of them are easy to take and some of them are awful. So tasting antibiotics, some people could say, well, it's not very wise for people who don't have an infection to taste an antibiotic. Very small dose, taste it and experience exactly what it is that you're prescribing for children, because it will change your prescribing behaviors, and hopefully choose antibiotics that are as narrow spectrum as possible that also taste good for kids.
Now, vaccines like, varicella and HPV have already made an impact on skin-related infections. But could we be doing more to that, or are there any emerging vaccine candidates specifically targeting skin infections like impetigo or boils?
Unfortunately, there's a lot of research, but none have made it to market as yet. So the Group A Strep vaccines have really focused on pharyngitis as a pathway to prevention of rheumatic fever rather than skin infections per se. But a lot of research shows that cellulitis and impetigo probably have an equivalent burden. And so I think any Group A Strep vaccine would be good to have as protective for both pharyngitis as well as skin infections. The reason the Group A Strep vaccines have been, slow to progress is that very early clinical trials back in the 70s showed that when they tried to immunise for Group A Strep, actually increased the chance of rheumatic fever. So there was a lot of inability to progress that research for probably about 20 years with an embargo on that kind of research. And so there's a resurgence now, but there's still a lot of work to do. And so I think we're a while away to having a vaccine for Group A Strep. There was also a lot of work done, and I think still needful, for staph skin infections. And the focus there was really surgical site infections and particularly rising rates of MRSA probably in the last 15 years. None of those vaccines have made it to market as yet either. So we don't actually have a vaccine as yet to protect from skin infections. And so I think all of our other strategies really need to be in play. We talked about hand washing previously, but also, attention to, particularly for small children, checking their skin every day, making sure that if they've got insect bites, that they're not causing increased itch, looking to see if they've got any scrapes or scratches that might need some antiseptic on them and a Band-Aid if they're not infected, making sure that you're really checking each child's skin regularly to see where those changes are happening and getting on top of them as quickly as possible. We find about 20% of kids under the age of 5 have eczema, and eczema is that dry skin pattern, and that puts them at risk of impetigo. So for parents with children with eczema, it's really important to moisturize regularly and, if needed, use the steroid creams that are recommended. So that's another strategy that parents can have to prevent skin infections getting worse. But we have to rely on those because we just don't have a vaccine as yet. Hopefully in the future we will.
So now lastly, Doctor, you've done some transformative work with the STOP trial, significantly actually reducing skin infection rates among Aboriginal children in Western Australia. So what are some of the key lessons or strategies from that initiative that could be applied in other high burden, resource limited settings worldwide?
Great question. So STOP stood for Seeing, Treating and Preventing Skin Infections. So that C component was about checking skin in school-age children regularly. And so we did those kind of skin checks, but we also provided a lot of education to families and to caregivers, both at a school environment and a healthcare, about what skin infections look like, how to recognize them, what the most evidence-based treatments were, and trying to get people really motivated about healthy skin and achieving it together. The T stood for treatment, and we were trying to make sure that the latest evidence-based treatments were available, that people were being made aware of them, and that they were accessible. And then finally, I think this is the most important part, the P stood for prevention, and partnerships with community were really foundational to this. And we spent a lot of time finding out what the healthy skin story was, what the traditional remedies, or bush medicines as they're called in Australia, were used to keep skin healthy and to prevent skin infections, and really tried to focus on that opportunity to keep skin in as good as condition as possible, so that barrier was well established, rather than having to come back and treat those infections. When we had this community-wide focus on skin health and taking that sort of lens of the community-wide, we saw a reduction over the course of the trial from 4 in 10 children having skin sores to 2 in 10 children having skin sores, which is still actually higher than probably most other communities in the world, but a massive reduction, 50% reduction. And I think it was that partnership with community, making something that everyone thought was simple, not that much of importance, a high priority, and working together to address skin infections, really with that aim of children having the best possible start in life.
Yeah, I think that is truly powerful, doctor. And the way community engagement and evidence-based care came together is deeply inspiring. So thank you for sharing that.
Thank you. I would say one thing we did do also was a hip hop video as part of that trial and the prevention activities. So I might be able to share the link, and you might be able to cut it in, I'm not sure. But the hip hop video was a really fun strategy for involving young people in an understanding of what the environment was contributing to skin health, and how they could go about preventing skin problems as well. So recording dance music videos with kids is always very fun, but then you also have this resource to share with other kids about how to stay strong and healthy.
Yeah, that's like a fun activity with a message, so it's really interesting, and you would love to see the link as well in the description below.
So, doctor, as we wrap up today's session, let me tell you that your work is not just about skin, it's about equity, access, and empowering communities through science. So, thank you so much for joining once again and sharing such insights with us.
Oh, I really appreciate that. Thanks, Happy. It's been wonderful to be here. And yeah, I do have such a strong values-based approach to science, that the world that we live in needs us to bring our values, to bring our best, and to make a difference for those who we can work with. So yeah, thank you for observing that, and a pleasure to be here today.
Thank you so much, and thank you for, and I think I would say, keep empowering the world with those values. And to our listeners, thank you for tuning in. And remember, if you're a healthcare professional who is deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and take care.